Good morning. Hi, this is Monte Eaves, and welcome to this edition of our video EBM Hub. This one is about meta-analysis, making the grade, and it starts actually with an interesting story. Several months ago, I received an invitation to review an article from Dr. Nahai, our editor-in-chief, in ASJ. And this was a meta-analysis on Rhinoplasty and the use of steroids. And I was so pleased by the tightness of the methodology and how excellent it was. I went directly to Dr. Nahai and I said, this would be a great example for how to do things right from the EBM Hub. He laughed, and the reason is that I didn't realize, because we have blinded evaluations for ASJ, I had no idea that my EBM Hub co-editor, Dr. Achilleas Thoma, was one of the authors on the paper. So I thought that deserved some explanation, and what we decided to do this time is something a little different. And instead of a normal type of explanation, really kind of interview the authors about what they're doing and why they did it that way. So today we're very happy to have Dr. Achilleas Thoma and Dr. Chris Coroneos, who is a resident there at McMaster and obviously very adept in issues of evidence-based medicine. Achilles and Chris, you note in your article that 3 different reviews of steroids and rhinoplasty had already been done with different results. Achilles, tell us what you were thinking and why you decided to go forth with this.
Well, first, let's talk about the difference between a regular review and a systematic review. A descriptive review is a summary or overview of a topic in which one summarizes what the literature says about the topic. This type of review is prone to bias. A frequent cause of this is the selection of the literature. The author may include only articles which he agrees and dismisses those he disagrees with. On the other hand, a systematic review uses stringent methods to answer a defined question. In a systematic review, one includes all literature sources, whether one agrees or disagrees with their findings. Afterwards, all the relevant articles are objectively appraised by at least 2 independent investigators. In this way, one attempts to eliminate the bias in the overall conclusion. The pooling of the evidence in a systematic review is done in a qualitative manner. In a meta-analysis, however, we will go one step further. We combine the extracted data from the included studies mathematically. Previous reviews on rhinoplasty included 2 meta-analyses and 1 qualitative review. The previous meta-analysis did not include all the trials which were available at the time. They did not pool the data appropriately, and they did not assess bias. The qualitative review relied on subjective assessment. Our systematic review sought to correct these shortcomings.
Okay, so Achilles, you mentioned the grade approach, and it seems this is your blueprint for analysis, if I'm reading you rightly. Chris, can you explain what grade really is and why it's important?
Conflicting conclusions do not provide direction to support the decisions made by surgeons and may compromise outcomes. In clinical situations where evidence is unclear, we can call these gray zones, we have a problem. In the present topic for steroids and rhinoplasty, a high level of evidence will have the highest impact to practice. This will minimize reviewer bias and improve interpretation. We use the GRADE approach in our meta-analysis. GRADE is an acronym that stands for Grading of Recommendations, Assessment, Development, and Evaluation. It is an approach to grading the quality of evidence and the strength of clinical recommendations. It was developed by a working group, including many members from our center here at McMaster University. Grading evidence is not new, and neither are these tools. However, GRADE addresses the shortcomings of existing tools. It is a transparent and structured system that evaluates the risk of bias, inconsistency, indirectness, imprecision, and publication bias. In the big picture, it has two main advantages. First, it is consistent for researchers to apply, and second, it is easy for readers to interpret.
Okay, so obviously picking the right studies to include in your analysis is totally fundamental to getting things right. If that part is wrong, then everything that follows cascades down in an erroneous way. So not only did you guys put a lot of effort in picking out the articles to include, but I noticed that you also put a lot of effort in applying several tools to assess the qualities of those articles. This quality assessment is something that I think many of our readers are really not that familiar with. Can you tell us about how you go about your quality assessment and how we as readers should use this? Achilleas?
A thorough literature review is mandatory for a systematic review or meta-analysis. We use exhaustive search criteria to identify all the sources of evidence relevant to the question being asked. After we identify the trials which are relevant to a topic, we ask three general questions. First, are the results of the trial valid? Number two, what are the results? And number three, can I apply the findings to my patient or practice? Application of a study's findings to a practice is more intuitive to surgeons. We know our work and make the connections. The validity question can be answered by assessing the design and execution of the trial. In the GRADE approach, we evaluate all the included trials with the Cochrane Risk of Bias tool. This tool considers 5 factors: randomization, allocation concealment, blinding, adequate follow-up, and funding source. By examining carefully each one of the above factors, this tool will tell us if there is a low or high risk of bias in the conclusions of a trial.
Gotcha. So in addition to looking at specific biases, you also mention other biases such as trial funding. Tell us a little bit more, Chris, about why this funding source is so important to understanding the bias which might sway our conclusions of a study.
Sophocles Vonescos, another resident in our plastics program, and our group recently reviewed funding and conflict of interest within RCTs in plastic surgery. Within the Cochrane tool, influence from a third party with a vested interest in the results of a trial is a risk of bias. Our research has shown industry-funded trials tend to favor new therapy. This is well described across other healthcare fields. A correlation exists between industry-funded studies with positive outcomes and pharmaceutical funders. Conversely, if a trial outcome is negative, industry-funded trials tend to report subgroup analyses, which is often a ploy to demonstrate positive findings. In our group, we did not consistently find an association between research sponsorship and study outcomes. However, this is most likely because it is underreported.
Totally get that. Okay, so next thought. It seems like a very challenging thing to combine studies where different techniques are employed and different metrics are used to measure outcomes. How do you do that? How do you take these mixed things and make something together that's going to be valid? So Achilleas, how do you deal with these differences, and how do you check to see what you combined has been done in a way that leads to valid conclusions?
When we combine outcomes from multiple trials in a meta-analysis, we have to deal with the problem of heterogeneity. The term heterogeneity means variability. For example, one trial may have considered cosmetic rhinoplasty in females. Another may have considered rhinoplasty in both sexes. A third trial still may have considered rhinoplasty in cleft lip repair patients. So the populations in these 3 trials are said to be heterogeneous. There may also be heterogeneity in the methods used. For example, one study may have followed patients for 2 years, another study for only 1 year, and the third study for only 3 months. We have a few ways of dealing with heterogeneity. In clinical terms, we try and combine trials with similar patient populations and similar outcomes. We may decide to pull the results of the Rhinoplasty randomized control trials that reported swelling up to 4 weeks and not those that reported swelling to only 24 hours. When we mathematically pull the outcomes between trials, we can account for this variation statistically using the random effect model, which assumes the studies are heterogeneous. To identify and measure heterogeneity among studies, we commonly use the I-square statistic. The I-square value gives us a statistical indication of the degree of inconsistency between the combined trials. If we cannot account for high variability within a priori hypothesis, we will have less confidence in the results.
Gotcha. You know, many of us struggle with understanding statistical terms and how to interpret. Can you give us a broad view of SMD and effect size? How is this calculated? Why is it important? And how do we as readers use this in critically appraising a study? Chris?
When we combine different scales measuring the same outcome, it is necessary to standardize the scale measurement used. For example, in edema and ecchymosis following a rhinoplasty, we can do this with the SMD, the standardized mean difference. If two scales for this example exist, say one a 5-point scale and one a 10-point scale, we can divide each result by its standard deviation. Practically, this gives us a standardized value such that the two scales can be compared. A critical reader will ask himself if it makes sense that these two scales were even combined. Interpreting this pooled value clinically is abstract for readers. When we convert into this standardized score, it is only a ratio without any units. Surgeons themselves don't express their outcomes in terms of standardized deviations. As a guide, an intervention with a small but noticeable effect has an SMD of 0.2. A medium effect is around 0.5, and a large effect is around 0.8. This means that if two groups don't differ by 0.2 standard deviations, the difference is clinically trivial. Seeing the SMD used in a study indicates different scales were pooled to arrive at a result.
Great. Chris, I think it's wonderful to see residents really involved in making such key contributions to the literature. For other residents and for those older students like me, be interested to know what really made you intrigued in doing this kind of study and how residents can learn to use the methods and tools you've discussed to complete a disciplined meta-analysis.
I'm a fourth-year resident in an integrated program here at McMaster University. I finished the clinician investigator program, completing a master's in health research methodology in the Department of Clinical Epidemiology and Biostatistics. My primary research interest is in knowledge translation. Early in my training, I became interested in why medicine does not employ best evidence, even when it exists. My research has since involved clinical practice guidelines, meta-analyses, and primary studies to demonstrate and remedy the gaps between what research tells us to be true and what we actually practice.
Okay, Chris, so here's where the rubber meets the road. You're about to do your first rhinoplasty in practice shortly. Will you use steroids or will you not?
Toughest question yet, Dr. Eaves, but this is where I have to trust the results of our study. If it's tomorrow, in the absence of any contraindications, I would use a single perioperative dose of dexamethasone, 8 milligrams IV. If it's in a few years, when I'm done residency and fellowship training, I'd have to consider what the best available evidence is at that point in time and act accordingly.
Thank you, Chris and Achilleas. I think this has been an interesting discussion. I've certainly learned a lot, and I hope those of you out there have. That's it for this edition of EBM Hub, and we'll be looking for you next time.